Well, welcome. It's so nice to see all of you here today. It really is. It's been a long time since we've been able to hold events like this with the SimplePractice community, and it's an absolute honor, pleasure to kick this off and bring things together today. Thank you to all of you locally here. We've got such a great mix of LA clinicians, some members of the media, and then those of you live. More than 5,000 today from the community streaming in, so welcome and thank you and for participating into today's discussion. It's really fantastic. Undoubtedly, we've got a great panel set up for you today, and I know it's going to be a really thoughtful discussion, but my hope also is that certainly we can make some new friendships, obviously delve into some deeper topics, but also maybe step out of our day-to-day and find a little bit of inspiration. And I think this is certainly a place that we can find that. The genesis for this a little bit is both personal and obviously tied to the work that we're doing here at SimplePractice every day, which about a year ago I had a chance to participate in a panel with Dr. Insel, and you certainly asked some tough questions for sure. But as I reflected on that, and over the subsequent months, as we kept in touch, I broached the idea with him of how do we have a discussion that really puts some of these big national issues that we're all talking about and seeing the headlines every day, but really through the lens of independent, private practitioners, just like yourselves. And as many of you know, more than half the mental health clinicians that operate in the U.S. operate in private practice. And small business owner, inspired to care for others. Life doesn't get necessarily easier with quickly changing regulatory environment, legislative landscape, clinical landscape, and then I think every day just demand for your services continues to increase. And we thank you for that, but it also means that we need to help as a company and industry make sure that we're elevating the voices of independent practitioners. And so I'm excited for that to happen today. Let me quickly introduce the panel. So grateful to have Rhitu Chatterjee here today to bring this to light. Rhitu comes to us from NPR. Long experience reporting on a whole host of different healthcare issues, particularly diving deep on mental health. So thank you, Rita. Really appreciate it. And then, obviously, two phenomenal clinicians here from the LA community. Dr. Jennifer Noble, Dr. Connor McClenahan. Dr. Noble has a thriving practice here, predominantly working with children, adolescents, and teens, particularly in underrepresented communities. Thank you. Dr. McClenahan has a practice downtown LA, has opened up some other offices across California as well, but predominantly sees adults dealing with anxiety, depression, and couples issues. So with that, I'm really pleased to also introduce Dr. Tom Insel. Thank you for coming today. Dr. Insel you spent your entire career, you continue to, devoted to mental health, both private and public sector, 13 years as the director leading the National Institute of Mental Health, and then as well as leading a number of high-growth software and technology companies, both as a leader and advisor, and continues to make a huge impact. So thank you for being here today. With that, happy to turn it over to Rhitu to take us away. Thank you.
Great. Thank you, Jonathan, and thank you to you all for being here and for SimplePractice for inviting me to moderate. And it really is wonderful to be in the same room with you all. After these last 2.5 years, I've been moderating a lot of panels on mental health, but this is the first in-person one that I've done since the start of the pandemic. So very happy to be here with our distinguished panelists. So I am a health correspondent with NPR, and I started covering mental health in 2018. And even before I could kind of get a grasp on what my beat was going to look like, I just started when Anthony Bourdain and Kate Spade died by suicide. So that was sort of the beginning of my journey covering mental health, reporting on mental health. And of course, in the last 2 years, it's come even more to the forefront of people's attention. And it's become much more openly talked about than, even 4 years ago. So I'm very happy to be here. And I want to start with Tom. Tom, you've been in the field for decades in different roles, starting out as a psychiatrist, then a neuroscientist, head of NIMH. So even before the pandemic, can you give us a snapshot of what you've seen, especially in the last couple of decades, about mental health in America?
Yeah, absolutely. Well, also delighted to be here, Jonathan. Thanks for bringing all of us together. This should be a really interesting conversation. Rhitu, it's been an interesting progression, and I guess if the thing that I was thinking about a lot in 2018, 2019 was what I'll call a disconnect. On the one hand, through my years at NIMH and even before that, it was sort of the golden era of progress in psychological science, neuroscience, cognitive science. It was really a remarkable time. And there was also a sense that when you talk to individual clinicians, they were quite hopeful. And while, clinicians always complain, but the fact is most people felt like, hey, I'm helping the people that I see, and I'm more helpful today than I was 10 years ago or 20 years ago. So you have this it's like a tale of two cities. You have this one city where there's enormous progress at the individual level. The other city is that at the population level, it's really dire, right? The suicide rate's up 30%. We're seeing more people with mental illness incarcerated, unemployed, homeless, on just about every public health measure of morbidity and mortality. Things are much, much worse. And so I think getting to that 2020 point, I used to say, 2020 is the year of perfect vision. It was anything but. Although I think what we did see was that this, during the pandemic, the appearance, that the evidence for that disconnect became even more apparent. But clearly that population versus individual experience to me was really the story of 2018, 2019.
And when did that really strike you? When did it start becoming sort of obvious to you?
Yeah, for me personally, I was doing a kind of a town hall meeting someplace on the West Coast, and I had my really cool PowerPoint deck, right, which every NIH Institute director will cart around to explain to taxpayers why they've made such a great investment in with their taxes. And I put up, the work with imaging and genetics and epigenetics and stem cells. And somebody got up afterwards and they said, you just don't get it. Our house is on fire and you're showing us the chemistry of the paint. We really are in a crisis. This was about 2015, 2016. As he said, I have a 25-year-old son with schizophrenia. He's been hospitalized 4 times, incarcerated 3 times, made 2 suicide attempts. and he's currently homeless. So that's the reality. That's what those population numbers are showing. And that's getting worse every year, in spite of the fact that we're making such fantastic progress on the science.
So I want to go to Jennifer and Connor next. And, Connor, can you talk about kind of going into 2020, what were you thinking, feeling, and seeing in your field? And the CDC and many other researchers have reported that in the past couple of years, symptoms of anxiety and depression have gone up in the population. So I'm curious if you have thoughts on what Tom said, like in the pre-pandemic times, and what started to become obvious to you once the pandemic started. What were you seeing in your practice?
Right. Well, I'm in downtown LA, and it was a pretty drastic change that happened when everything shut down. Nobody was coming into work anymore. But right before that, it felt like there was a lot of activity. It felt like people were generally hopeful. I can think of a client who, even though she was depressed, she could still generally present like herself and talk about what was happening. And just, 2 months later, I remember getting on a video call with her, which we had never done before. And I remember seeing her panicked and looking like she was kept switching her attention and looked a little bit paranoid. And this is somebody who I'd never seen this behavior before with. And it was just remarkable to me of what happened. She had been inside of her apartment and hadn't left for 3 weeks. And just what happens to a person when we're removed from a social fabric, when we're removed from our rituals and connection with other people. That's a moment that I can think of that felt really clear to me of just what it feels like when those things are taken away. Yeah.
Somebody who had been successfully managing their symptoms becomes much more serious. Mm-hmm. And what have you seen in the past couple of years? How have these numbers that have been reported by the CDC sort of played out in among your clients?
The numbers concerning?
Around people experiencing more symptoms of mental health problems.
Right. I think a lot of us are experiencing more severity in the symptoms that maybe we already had. That's my understanding. I think it's also exacerbated by, people moving. Let's say I'm thinking about several clients who've moved to a new place or taken a new job, and kind of what you expect when somebody moves is that they get transplanted and they kind of slowly grow roots in, and yet there's no atmosphere for them to do that. They're not going into work, they don't have friends there, and there's no places to make those connections. And I think that for all of us, when we lack those things, all of our symptoms get worse, whether it's anxiety, depression. Mm-hmm.
And Jennifer, you work with teens, and I, especially during the pandemic, have been really following closely what's been going on with children and teens and youth. And many of you might know that the Surgeon General put out this advisory last year about the youth mental health crisis, the fact that the pandemic, which has taken a toll on many people's mental health, but kids and teens have been particularly hard hit. 3 groups, healthcare organizations for kids and teens, have declared a state of national emergency with kids' mental health. So I'm wondering, what have you seen in your practice with the teens that you work with? Perhaps have you seen newer clients in this time?
Yeah, I think with the teens that I'm working with, it's shocking to see how quick of a decline that occurred for them. Because if you really think about it, kind of what you were saying, like your environment that you're used to. For teens, their whole life is school. You kept the worst part of a teen's life, which is the schoolwork, and then you took everything else away, and you just saw the impact. Where, for me, the way I would kind of describe it is like extreme isolation for these teenagers because they're now stuck at home doing everything on a computer screen. Some kids are on camera, some are not. So now you're maybe looking at 1 or 2, 5 people, depending on, how the teachers make the rules. So isolation, and then just a lack of purpose. I feel like so many teens that I talk to were just like, what is the point of anything, of just being here? And of course, it really is alarming because you're like, is this suicidal ideation, or is it just the reality? What really is the point of doing math homework for no reason? I can't see my friends, I can't have lunch. So for me, once we had kids returning to school, I saw a lot of teenagers just returning to themselves. So you know how much of an impact it was. And some are still trying to get their bearings back, but it was such a disruption.
Yeah.
One of the things we've been looking at are just the numbers for kids in terms of mortality during this period. And so to Jennifer's point, if you look at COVID overall in the United States, we've had about a little less than 1.1 million deaths. But for people under the age of 30, all in, COVID deaths range to about 8,000. 8,000 out of 1.1 million. In that same period of time, for that same age group, the number of deaths from mental health related issues, suicide and drug overdoses, we don't have perfect numbers, but the best guesstimate is about 120,000.
Wow.
So like 15-fold higher mortality from psychological causes compared to COVID.
Yep.
So to her point, I mean, this is really a public health emergency that we haven't quite reckoned with as a country. We certainly did that with COVID, but oddly enough, this one is now continuing.
That's what I was going to say. We may be dealing with this for a much longer time.
Yeah, I mean, we know that from other massive public health emergencies, or like if you just look at the 1918 influenza, the psychological pieces of that, or the 1929, crash of the stock market. The psychological consequences are a long tail, usually 3, 4, 5 years out is when you see the biggest consequences. So I think we're still in the early phases of this.
And we're still talking about economic impacts persisting on families, and that's going to take another toll too.
Yeah, it is, but what's weird, and this is why I think this is so important, if you step back, you might not have thought that the age group that would have the biggest morbidity from this and mortality would be 15 to 25, because they are in some ways the least affected by the virus itself. And yet, that's what we're learning over and over again. They really are a vulnerable part of the population in a way that hasn't gone away, that will continue.
Yeah. Well, this also means that it's made all your work more meaningful, but it's, I imagine, put a lot of pressure on mental health care workers. And I mean, all healthcare workers, right? I've done a bunch of reporting on, healthcare workers were already burnt out before the pandemic started, and then you throw surge after surge. And you all have been under tremendous pressure, often yourselves working in isolation, talking to your clients virtually. So my question for both of you, Connor and Jennifer, is, and maybe Connor, you can take it first, can you talk about the mental health toll of your work during the pandemic?
Yeah, I think right before the pandemic happened, we opened up an office. We were pregnant with our 4th child, and I remember when everything closed down and we had our 4th child, and our our family couldn't come visit. I remember them visiting through the glass window.
I'm very familiar with
Yes,
that. Yeah,
yeah,
I had my
uh-huh.
first child right at the
Oh, my
beginning of the
goodness.
pandemic.
Yeah. And so I remember doing Zoom calls for the first time, and feeling incredibly isolated, anxious myself. And it's really, I feel like the things that can get us through suffering are if we have a light at the end of the tunnel, if we can kind of see the end point, and if we can share it with others, if we can feel like we're in it together. And those things were really difficult, I think, that I was aware of, where I just felt isolated, and you have this feeling like, when is this going to end? And you don't know. But I remember kind of having this moment of doing the Zoom calls and realizing that our other clinicians are kind of going through the same thing, and the kind of isolation that they were experiencing as well. I think there was a moment later when the restaurants eventually opened and I could take them all out to dinner and connect, and it was just this moment for me of feeling like, okay, the pandemic is far from over, but in the middle of the suffering, we can be together, and we can somehow enjoy and be grateful for something together. And I think those kind of moments got me through and had this big wash of relief over me of just feeling like, even though something, it's not like the suffering is gone, we can still share something together.
What about you, Jennifer?
As far as how do I feel clinicians were impacted?
Yeah, yourself or your colleagues.
Yeah, I think for me, what I noticed was one, I think I was talking about it with a few people here. When the pandemic hit, business was booming, and you're like, hey, so many clients, and then you're like, oh, so many clients are needing. So at first, you're getting this influx, especially if you work with specific populations, whether it's minoritized or certain cultures, you're getting inundated, and so you think, okay, great, people are finding me, they're looking for help, and you can help them. And then when you get full, and you're like, don't worry, let me call my friends, and then you're like, they're all full, and then you stop and you're like, there's nobody left. And then you find, at least for me, you find yourself like, okay, could I do one more hour? How can I see this person? Because they're telling me they called 17 people and 8 called them back and said they were full. And it's a pressure that, of course, is not mine, but at the same time, it's like, it is, So I think then, for me, being able to talk to some of my colleagues about that and see that we were all experiencing the same thing of, gosh, I don't know, I'm full, do you know so-and-so, what are you doing about this? And maybe it forced some creativity as well to reach people in new ways.
And actually, that's a great segue to what I was going to talk about, the overall shortage of providers, which existed before the pandemic. And then you're talking about the providers that you do know being completely full. And I'm assuming that in the age group that you work with, it's even more severe. So what are the creative solutions you've used? And I'm wondering if you and your colleagues have thought about ways to address the shortage in the long run. How do you make this a viable, inviting career for young people to come into and make it sustainable?
You're laughing.
You're funny. I mean, I am not sure how to answer that, because I do think a lot of people, when they think of mental health work, they think, oh, I can't, it's too much, and they don't, maybe they don't understand what actually happens to think that it is possible for them to do. But specifically for me, because I work with teens and children, I do feel a lot of people don't want to work with those populations. I always say people do not like teenagers. They love children and they don't like teenagers. And so even when I had people to refer to, I would call them and they'd say, oh yes, maybe I do have an opening. How old is the kid? Oh, they're 14. Oh yeah, no, past puberty, don't do it. I stop at 10 or, something like that. And I think perhaps to your question of how do we increase, my feeling is that I think there would have to be some destigmatizing of adolescence. I don't know if that's a controversial thought, but I think probably societal views of adolescence is quite negative, and oh, they're too angsty and oh, this and that. But then they get ignored, they're not sort of visible, their needs are not met, and they're viewed as just a problem. Most of the research, at least that a lot of the research I come across is like, whether it's like substance abuse, teen pregnancy, delinquent youth, this, and no one is really sort of normalizing the process of adolescence and individuation and identity. And if we could do that, I think maybe more of everyone would be willing to say, oh, okay, I can help you through that very normal process that we all went to. Seems like everybody forgot that they were also a teenager. So I guess that would be my answer, is in order to increase more, increase the numbers of clinicians that want to work with adolescents, you'd have to destigmatize the population and make it look desirable. And I think teenagers are super fun and great, and I would help destigmatize that, but I don't think a lot of people are.
Yeah. Connor and then Tom, from your vantage points, if you've thought about ways to address shortage of providers. And I should also throw in, if either one of you have thoughts on, talking about shortage of providers, on the one hand, we're talking about getting more people in the field, but then we also have to talk about to prevent people leaving the field, which I hear from providers all the time. The burnout, the difficulties in getting, or the low reimbursement rates from insurance companies. So that's a huge issue, and so that's definitely sort of fueling a big part of the burnout, not just sort of people's workloads. I've had providers tell me that, you have people with doctoral level degrees, master's level degrees, not getting paid enough, and the work doesn't feel, and this is tremendously hard work. So Connor, if you have thoughts on either how to get more people in, retain more people, and then Tom, I'd love to hear from your perspective as well.
Yeah, I think I thought about this a lot, where how can I do more outside of the 45-minute session to help people feel comfortable with reaching out. I think often as therapists, we don't see marketing as a clinical act. We see it as like a business thing that we do, as opposed to part of our clinical role of how do we help people feel confident and encouraged and comfortable enough reaching out and coming in. So I think that's part of it. I think there's some great resources that some clinicians have developed to help people with daily mental health things, where they're thinking outside of the 45-minute hour of how do I create digital resources to help people with either connect with each other or explore more deeply or find different solutions. So I think that's something that is becoming more and more available for people. I think it's a good thing. Also, on the payment side, there's another part of me that doesn't want to put more pressure on any private practice clinician to like do more to reach out or something. I think there is, to your point, a way that there might be a lot more therapists available for people if insurance companies paid a market rate for services, right? We don't ask that of other clinicians or other professions. We don't ask that of other professions for them to do really heavy marketing or creative thinking. If you're a nurse or a doctor, you count on going in and insurance companies providing enough for you so that you can make a good living. And I think if we want more therapists that are helping people with this crisis, we count on fair reimbursement from insurance to make it an attractive profession.
So I don't understand the problem, because the numbers don't. Again, I'm kind of a number person. That's my background in science. But if you
look, don't understand the shortage of providers?
Mm-hmm, yeah, I mean there are over 700,000 mental health clinicians in the United States. So just for context, there are less than 200,000 primary care providers. There are less than 200,000 dentists. So there are a lot of people. There are issues with their geographic distribution, but that should be to some extent, overcome during this era of telehealth. There are issues with their availability. But on the one hand, you have huge numbers. On the other hand, I hear this all the time. You know, I've called 9 people and no one has availability.
I hear that all the time from my
Absolutely,
sources.
that is the experience. So it's still, this is my day to talk about disconnects, but that's for me still a disconnect. I don't know with over 700,000 clinicians why it's so hard to find somebody, except that the demand may be way up. And so, you know, the supply, even the supply we've had, may not be adequate. I have a couple thoughts about what one could do. And one of the ways in which this gets resolved, I think, is by changing the models by which we think about how we do what we do. So there's a huge interest in the developing world about bringing in other kinds of clinicians. Sometimes those are people with lived experience, sometimes they're coaches.
Sometimes they're grandmas in neighborhoods.
I was just about to say, you know, the friendship bench in Zimbabwe, where you have a grandmother, a granny, who provides wonderful coaching for young moms. And so maybe we have to begin to think about the problem a little differently, think about who can actually begin to close that demand-supply gap. Back to Connor's point, at the end of the day, you still have to pay for this if you want it. And so the question has to be asked, who's going to pay and how much will they pay? And I think, honestly, I think the system we have is the system that we've incentivized. You get what you pay for here. And it's maybe not surprising that it's hard for people to find a clinician if many clinicians feel like they can't get paid well enough through an insurance plan or through Medicaid to make it worth their while. So we're going to have to look at this as a policy issue, or let's just call it what it is, a payment issue as well as just an availability issue.
Well, so I want to get to, since you're talking about payment and not paying, you said we're getting what we pay for. And in your book, you write about how we haven't really focused on recovery in serious mental illness. Mental illness requires an approach with 3 Ps, people, place, and purpose. Can you talk a little bit about that? And how do we get to a place where we pay for that? And as you've said when we were talking earlier, that's sort of the 4th P. Payment.
Yeah, so the book, which is called Healing, was really trying to fix those disconnects, trying to explain why we hadn't done better. And where I ended up, as Rhitu was saying, is with the sense that we're really investing on the wrong model. What we have is a kind of narrow medical model that says, particularly for people with serious mental illness, we'll take care of the crisis. We'll pay for the ER visit, we'll pay for your inpatient stay, and we'll pay for your medication. But after that, you're on your own, right? By the way, we don't do that in orthopedics. Right. You break a leg, you're going to get pretty good physical therapy and rehab for 6 months, maybe a year. But you have a psychotic break, good luck with that. You're not going to get any of those rehabilitative services paid for. And those services are the essence of those 3 Ps: people, place, and purpose. Social support, like we're talking about, having community, having a safe place to recover so you're not homeless, you're not incarcerated, and most of all, having a sense of purpose, having something to recover for. So those are the 3 Ps. And the frustration here is we know how to do this. This is not rocket science. We know that there are groups that can provide that community, that social support. We know that clubhouses and other kinds of institutions that are out there do provide that safe place. And giving people a sense of purpose means helping them with supportive employment, with work, helping them to get back to school, helping them to actually even use their own lived experience as a peer. So how do we pay for this? When I finished the book, I actually didn't have any idea. But I started a company because I realized that if healthcare is a business, which it is in the United States, it's not necessarily a business in much of the rest of the Western world, but here it's purely a business. We have got to figure out how to incentivize the things that work. And so what we're trying to do, the company's called Vanna Health, B-A-N-N-A Health. And what we're trying to prove out is that if we build those 3 Ps, we'll save insurance companies a lot of money. And so they should start paying for this. And it's not that expensive. We know that 2 weeks in the hospital costs more than a year in a clubhouse, right? It's not, and to have an ACT team which goes to someone's house, that's a little expensive, but you actually save so much because every ER visit, every hospitalization, besides being a tragedy for the person, is also a real burden economically for all of us. So we've got to think of a better way to do this. We're spending almost $4 trillion, 19% of our GDP, on healthcare in the United States. And yet, for things that really do work, that actually support health, we don't pay for them. And that's really what we're trying to prove out and figure out how to change that.
And so can you be a little more specific about how you're, what's your experience so far with the startup and trying to convince insurance companies? What's that been like?
Yeah, it's weird, Rhitu. They're really excited about this because they think they're going to save money.
So it's all about the marketing. It's all about the framing.
That's right. And the VA has already done it. There have been lots of experiments where this has been shown to work pretty well. I think it just hasn't been taken to scale. And what you see in every community we've gone into is that there are individuals who are doing great stuff. It's fantastic. I mean, there are clubhouses, there are ACT teams, there are peer support groups that are really doing beautiful work. But they don't all come together as a system of care that makes it easy for an insurance company to pay for, or even for Medicaid to pay for. The good news is here in California, with the new waiver we have for what we call Medi-Cal here in California, all this becomes part of healthcare. So as a clinician, I can write a prescription for housing. How cool is that? I can write a prescription for food for someone who's food insecure. So there's really now, there is a way forward in California, which makes me super hopeful, because all of a sudden we're defining mental health as something more than traditional mental health care. I think that's pretty cool.
It is. And this sort of brings me to the more sort of hopeful time that, based on our previous conversations, we seem to be living in. As we've talked about how conversation around mental health has gone up with the need. But also, Tom, when you and I spoke in the spring, right after the State of the Union address, where President Biden gave significant number of minutes, what psychiatrists and mental health care advocates tell me it's the first time ever that a State of the Union address is included.
1963, we had a pretty good...
Was the last
yeah.
one. And as you and many others have pointed out to me, there is significant, and I see this in the legislations passed recently, that there's significant bipartisan support in addressing the country's mental health crisis. So talk about what makes you most hopeful in terms of policies and investments you've seen recently, and what, if you can pick one or two things that you think are going to make the biggest impact in communities and in the lives of people.
Well, maybe we should all do this. I'd be interested to get your thoughts as well. I'll be real quick. I think for the last 42 years, the federal government has not really had a leadership role in anything related to mental health. They passed bills on parity, they passed a number of bills, and there have been even a few presidential commissions. But, you know, it's largely up to the states to figure out what the services will be. And that's changing in two ways. One, it's crisis care has become a big federally mandated program. The 988 service now needs to be in every community in the United States. So this is a mental health crisis number. You'd think it would be for text and chat, and we'll get there. But it's just starting, and I think, like with 911, which took many, many years to really roll out, this will take a while. But it's a significant advance because it's trying to move away from the criminalization of mental health, trying to make sure that we don't involve criminal justice. People go into healthcare, they're not going to jail, they're going to a clinic. That's a good thing. I mean, ultimately, you don't want to have a crisis at all. That's not where you want to end up. But for now, I think it's important. The second massive thing is in the 1960s and 70s, the federal government ran a federally funded community mental health system all throughout the United States. That's bananas if you think about it. Like, we haven't really done anything like that since. We do have a federally qualified health center system, federally funded community health systems for primary care for the indigent population, just about, in all 50 states and territories, 6 territories. But in the last couple of years, and really mostly in the last couple of months, actually just last Wednesday, the White House put out a statement that they were making massive investments in what they call the Certified Community Behavioral Health Centers, the CCBHCs, which will be like the federally qualified health centers, but for mental health, and they'll say behavioral health for both serious mental illness and substance use disorder. The pilot form of this has been around for about 3 or 4 years, but what really changed everything was the Bipartisan Safer Communities Act, which is actually supposed to be the gun bill after Uvalde. So this was passed the last week of June this year. Uvalde was in May, I think. So it was about a month later, end of May, early June. And this, I don't know that this is really a gun bill, but it's a remarkable bill for mental health. It ultimately puts over $9 billion, I believe, into this CCBHC program, and it moves it from a grant program to an entitlement program under the Center for Medicaid and Medicare Services. So that's a massive, massive change. And it expands it to all 50 states. So, we're in a new world.
Why is that so important? Like, what do you see these clinics? What kinds of services are they going to provide? And one thing that struck me was the fact that regardless of whether anybody had insurance or not, they were required to provide care.
Yeah, well, so they're rather prescriptive. The kinds of things that these centers have to provide, particularly for the Medicaid population, but for any indigent population, is really whole person care. So it's primary care, it's crisis care, it's substance use disorder care, and it's a range of both acute and rehabilitative services for people with serious mental illness. So it's pretty ambitious, and there's a lot on the plate. Maybe the most interesting piece of it is that it's an innovation on payment as well as on practice.
How so?
So it's they are funded prospectively. So you'll get, if you're running one of these centers, you get a pot of money to cover the population that you're serving, and you get to decide how you want to spend that money. Do you want to spend it on building clubhouses, or do you want to spend it on doing neurosurgery? It's up to you. That's really, I think, particularly exciting because it begins to move us towards what we'll call a value-based system of payment. focused on outcomes, focused on actually serving a population in a way from counting how many minutes were you spending with this encounter and getting reimbursed in a fee-for-service kind of volume-based approach. So this is all really cool stuff. I mean, it's kind of geeky and policy-driven, but it really could make a massive difference for a part of the population, 14.2 million people, who have been really marginalized and have ended up in jails, ended up homeless, just because they haven't been able to get care.
And Jennifer and Connor, do you share Tom's optimism around policy and, at least at the federal or the state level, investments into the mental health care system? And do you feel engaged at the policy level at all?
I've learned a lot. I would say I am not as aware of more recent public policy in this regard. So it feels a little promising what you're sharing, but from my end, I wonder about the population that is kind of missing in that, because it sounds like it's a little bit leaning severe, higher suffering, really poor functioning. So I wonder what happens to the people that are like, look, I'm not doing well, but I'm trying to help myself before I get to this severe level. And I don't know, but I just don't hear all that you said covering that group of people. And I think that population or that segment has a really big need. So I do wonder about that. And so I guess to your question, I really would be more excited about any public policy that is just going to increase access for people that want it, rather than someone else deciding the need and saying, oh, you really need it, and you go, you're fine, according to me. I'd rather it be, here is a way for you to take care of yourself and you being able to access it. Just like if you want to go to the doctor and say, my stomach hurts, and then the doctor's like, your stomach is fine. And you're like, well, thanks. I might be back next month.
So investment in more on the preventive side of things, so that you don't get somebody here moving on this continuum.
I mean, I wouldn't even call it preventive. I mean, just blanket mental health care at all levels. Low level where I'm worried about my stress and my anxiety and I want to be able to work with someone, and then I'm really severely in need and my family members need to take me to someone, and everybody in between. I feel like a lot of the policy, and I understand why, we are a country that goes to squeaky wheels, so the squeaky wheel always gets the oil, but sometimes there's another wheel that needed something and is just not squeaking yet. So I, like I said, I would be more excited and wishing for policy that gets at
sort of the continuum of care.
Yes.
Connor, you have thoughts on this?
Yeah, I like that idea about local organizations being able to allot money to where they think they have need. I like that bottom-up approach. That feels really helpful. The thing that I get wary of is some kind of bureaucratic top-down system where a lot of things you can kind of see on the outside, there's a lot of things happening, but you kind of always wonder how much of this is actually creating a need or meeting a need, and then how much of this is kind of just almost trying to show that we're doing something with the money. So I like
talking about having accountability where there are investments.
Sure. And something else I wonder about is, if we think of ourselves as a collective there's some ways that we could probably think of, okay, well, this person needs more, intervention or services, or this person needs, but I kind of wonder also what it speaks to what we all need, how there's something missing for all of us. And so I like the idea of what are the things that are getting in the way of us providing care for each other? What are the things that are getting in the way of us knocking on each other's door? Those kinds of interventive...
So you're talking about the social fabric, which has been sort of really tested these past couple of years.
Yeah, what is getting in the way of that, and how do we address those pieces too? And I'm not sure,
Tom, do you have any thoughts and reflections on what Jennifer and Connor just said?
Yeah, I mean, there's lots of, we could do this all day. This is good. Lots of thoughts. Let me start with Connor's comment, because when you asked before about the workforce shortage, my first thought was a company that I co-founded at the very beginning of the pandemic, mostly for university students, called Humanist Care, and Humanist instead of Humanist. The idea was just what Connor was suggesting. Because we had this enormous shortage, particularly in university mental health centers, could we train students to help each other? Could we create community? And we learned a huge amount. And the thing that we learned the most was that students really wanted to do that. And that we were working at UC Berkeley mostly with several thousand students there. And what was so wonderful about it was it became very clear that what was most therapeutic, most helpful, wasn't for them to get help, but to give help. We never do that in healthcare. We don't empower people to help each other. But ultimately, the workforce shortage could be really addressed in a brilliant way if we can give people the tools to help each other, like we do with AA, or with a whole range of other, even with sometimes in the faith community, where we're very good at creating community. And it was so clear during the pandemic that there was an appetite for this. At one point, we asked students, would you rather have a one-on-one meeting with a credentialed therapist or become part of an asynchronous group chat treatment group with a moderated with a therapist who would moderate it, but you'd be in with 19 or 29 other students. 68% or 69% of the students chose group chat, the asynchronous group chat. Maybe it's because they're digital natives and that's kind of their comfort zone, but I think really what it was they wanted to know that they could help each other.
Yeah.
And they could. They really did. It was phenomenal how effective that was. So I'm totally with you on this idea that we need to find a way to build community and I must say, this is my day to trash the medical model, but this kind of hierarchical thing that we are the experts with the answers that people have to come to one at a time for 50 minutes a week, maybe that's just not like.
Well, it's interesting you bring that up. I'll share an anecdote from my own personal experience of starting my journey as a mom in the pandemic. We brought our son home on the 8th from the hospital, and on the 11th, the lockdown started, March of 2020. And about a month later, I decided to join a long-standing group. I think it's just called Parenting and Childhood Education. They're called PACE. You pay a certain amount of money. You do like 10 group sessions with a moderator who's either a therapist or just a parenting, child-raising expert, childhood development expert. But then the magic of it is, it's then the rest of the group is connected by a WhatsApp group. And they became my lifeline, and we remain friends today. Like, I don't think any of us, especially during that time of isolation, most of us I think all of us were first-time parents. It was just so therapeutic. Anyway, so I'm really glad I can relate to that. But I want to switch tracks a little bit, and can't talk about the pandemic without talking about, both of you have mentioned reaching clients virtually, and there was a great thing that happened during the pandemic, that restrictions about access to virtual care were taken away. But now that might be changing, and I'm wondering if both of you have thoughts on, as the public health emergency might end, and like many states have already started rolling back on paying for virtual care. How do you think that would affect access to mental health care? Jennifer, do you want to go first?
Yeah, I am concerned about that. I think for me, my own observation is that adolescents, I work with adults as well, and I think they can return to in-person, and maybe they'll complain about traffic. I mean, I'm in Southern California, so a lot of people were like, oh, you mean I can just have 50 minutes and not have like 45 on either side? But for adolescents especially, I really feel there is a difference for an adolescent to do therapy from home or have that option. I think a therapy office might be very clinical for a teen. I can see their body language change where they're sort of like, yeah, so, maybe the office could be really nice, but they're sort of like, I'm not comfortable, I don't know you, this now feels very formal. Whereas when they were forced to go home, I'm seeing them curled up on their beds and, snuggled up with something, feeling freer to express and cry and just be more honest. And and not to mention be able to keep up with their very busy schedules. And I think there will be a lot of disruption if they are not sort of able to keep that option. And so, that's what I would be most concerned about when I hear about rolling back the telehealth. Yeah.
Yeah, I think that it would cause a lot of disruption just because people don't just go to therapy. They go to a certain therapist that they have a relationship with. And a lot of people have built these relationships over telehealth with certain therapists, and they're not able to come in for whatever reason. It's not accessible. And so I think that would be asking a lot of people to just stop seeing their therapists at all, or not be able to afford it. Also, I kind of hope that some of the legality around where your client can be while you're doing therapy, I hope changes and needs to change. I think it becomes sillier and sillier to think about, well, okay, you have for 3 months you're in a summer home and then you're over here, but then you're on vacation. So at what point do we just go, all right, whatever, just just see my client wherever they are, and help maintain that kind of relationship. So I hope that kind of goes in that direction, but I can't imagine it would be really disruptive if telehealth had to be more limited.
Tom, I'm curious, since you're engaged at the policy level, what you're hearing and sort of what are the conversations around this?
Yeah, I think the policymakers are learning that this is both safe and effective. I think there's a sense that they really do want to, they don't want the public health emergency to continue, but they want the flexibility. It's going to change in some ways, and a lot of this is going to be driven by states, not by the federal government. That's a problem, by the way. I'd love to see the federal government put some leadership into this issue and say, look, it shouldn't matter whether you're in Michigan or Wisconsin. These are the rules that you can go by. States still want to keep their hands on the regulatory part of this, which I think this is really, it should be a federal issue at some point where we say, look, telehealth is a form of health, particularly in the mental health space where there's been such a problem with access and geographic distance. We've got to maintain this for public health needs. It's one of the reasons why I keep using these numbers about the mortality from COVID for behavioral health reasons, because I think the policymakers need to understand the cost of not doing this well, that we have to do more, not less. And so starting to restrict access doesn't make a lot of sense to me right now. I hear this from both Republicans and Democrats, and the Senate Finance Committee, which has gone deep onto this topic. I think there's bipartisan support for the idea of expanding, not restricting telehealth.
So
I just wanted to add one thing. There's so many corporations that have realized, during the pandemic, they had to figure out how to let all their employees work from home, and they were still able to get their job's done, and then pandemic is over, and they had to realize they have to say, if you'd like to come back, we'd love to have you, but also we realized we started this thing. The toothpaste is out of the tube. I mean, I think the same thing is true for telehealth, teletherapy. You can't, it's done. So adjust, make it better, make policies that just support what's happening and improve it from here. Don't try to go backwards.
I think that's a good, it's a good way to frame it, that it's happening in every industry. The question here that I think people are struggling with is, are there some limits? So is it okay to prescribe medications that are scheduled, like Adderall, without seeing a patient? The Ryan Haight exclusion, which right now during the health emergency has been lifted, that particular regulation. Do we bring that back? Where are the limits of telehealth? And I'm not sure we've fully defined that yet.
Well, I have lots of other questions. We could keep talking, but I do want to open it up to questions. But before we do that, very quickly, if each one of you have a quick parting thought or remark about where we're headed, how do we address this crisis, and access to care. Anything we have touched upon or haven't?
Well, I will, since everybody's looking at each other. I was thinking, if nothing else in all that we're talking about, I think we really need to have a discussion about culturally competent care for so many different, there's just so many cultures, whether it's gender, religion, I mean, you name it. And I think a lot of this discussion and, creating community and really recognizing how different cultures create community, we have to be able to incorporate that into our work, our policy, just keeping that as a top awareness, because so many more marginalized populations are like, oh, maybe I will consider this now. I will consider therapy. We can't, we have to meet them.
I'm so glad you brought that up, because some of my colleagues over at the Invisibilia podcast just did an episode on that, about how, I forget exactly what part of the country this community behavioral health clinic was based at, but for years, like about 90% of this Cambodian community that was coming to the clinic were all being given medications of psychosis, until the psychiatrist joins there and says, how can that be? Yeah. And the fact that these refugees, Cambodian refugees, all came from war, was completely not taken into account at all. And it was only after this particular psychiatrist who took it upon himself to hire another Cambodian who had cultural knowledge. And even this person was trained in Western, more individualized approach to mental health care, had to kind of re-educate himself and kind of go back and relearn about his own cultural things that he could then use. And again, we've talked about payment and everything. One of the things that struck me was he realized all the things that needed to be done to really help this population would not be paid for. Taking them to church appointments, or like taking them to the Social Security office, making sure they, to build trust over time. So thank you for bringing that up. Tom, were you going to add something?
Yeah, I guess we've talked a lot about access, and we've talked about how we're in the middle of, I think, a transformational moment, still pretty early. I sometimes talk about this transformation as kind of a 5-act play, and I think we're still in Act 1, which is how do we close that supply-demand gap? How do we make sure people have more convenient, more rapid access? The next piece of this, the Act 2, is going to have to be, how do we raise the bar on quality? How do we make sure that people are getting not just more care, but better care? it's a place actually where I think SimplePractice can have a role, and actually thinking about what can we do for 140,000 clinicians to help them provide higher quality care and to get better outcomes as a result. And
what could those things be?
what
What could those steps be to make sure?
well,
to
usually, I mean, what we think about are things like measurement-based care, collaborative care. There's just like, there are now a bunch of touchstones that people go to improve quality, but most of all, it's beginning to at least measure outcomes. Because ultimately, in all of healthcare, we'll be paying for outcomes, not for time spent. It will go from volume-based to value-based. So I think, getting started, that's really Act 2. Act 3 will be just what we were talking about, is making sure, and maybe this needs to be part of quality, that we're providing the kind of care that actually matters for an individual, that it's much more culturally competent. And we're going to have to bring in, I think, the wider tent, that there are still so many people who could and should benefit from psychological treatments who aren't getting them. And we have to figure that out. We have to cross that bridge. And then there's a couple of other acts around regulation, around payment reform, a bunch of other things. But those are the things that need to happen next.
Connor, do you have any parting thoughts?
Sure, I think this is just really important to reflect on where we are. It feels like not just a moment to reflect on people who are having an issue, like people who are severely mentally ill, but how does this reflect on what all of us need, and what are we learning about what we all need as a collective to function well? Our minds are made to be bathed in social relationship, and there have been a lot of things over the last couple of years that have gotten in the way of that, and I think we all suffer in some way. And so it just feels right to be able to reflect together about where we are and how do we learn more about what we all need together.
Thank you all so much, and I'll open it up to questions from the audience, whether digital or people here in the room. Do we have a mic for...
Hello, I don't know if y'all want me to stand or not, but thank y'all so much. This is a very rich conversation. I think I want to make a comment about, I think you asked the question about retaining practitioners, clinicians, like the number of people that we have providing services in the community. And I know Tom said, I don't know if there's a problem. And I think that pay is a problem, how we're getting paid, but I do think that we're missing two critical issues here. I think one is licensing. Licensing is a huge barrier for folks who look like me, other people of color, to even enter this field. I'm a psychologist, and I had to take the national licensing exam twice. And that was just my experience. Other people who look like me and other people of color have had to take that test up to 6 times. So to even get in this field and be a person who provides care to people who are needing care, that is a huge barrier that must be addressed. And then having grad students pay $600 for a test that they don't have money for. And then that's just the national level, and then you got to get licensed at the state level. I'm also licensed in California and Texas, and to get licensed in both of those, it's a huge privilege to even be standing here and have crossed those barriers, right? So I think we got to be cognizant of that. The other one is insurance companies panel who they want to panel, right? And so there are a lot of people, black people, who have come to me and said, I'm calling around trying to use my insurance, but they're telling me that my area is saturated.
Right.
Meaning there's too many therapists in your area doing the same thing, but the problem is that those therapists don't look like the people who are trying to get the services. So while there are numbers, there aren't the numbers that people are wanting. They're not the people who people want to see, who looks like them, because there's not the shared experience, there's not the cultural responsiveness, and so these are the issues. And so we have to start thinking about those things and addressing those things and being honest about those barriers that exist. In the 2020, at the beginning of the pandemic, I released a card deck for black folks, mental health card deck for black people, my therapy cards. And it was because there's a barrier that exists for a geographical location. Who can access care? Who can I talk to if you don't look like me? So I put the cards out. I put the questions that I asked my clients in a card deck and said, no matter where you are, you can do these questions yourself, or you can work with your therapist. So I think as professionals, we've also got to get really creative about how we actually overcome some of these systemic things that are in place that makes it hard for people in our communities to actually access care.
Thank you for that.
But before you give up the microphone, can I ask you, how long did it take to get licensed after you had finished?
So I graduated in 2012. I was on internship here in San Diego, finished in 2014. I failed the first time, and then I had to take it again 3 months later, but I had to pass it before I got my offer letter for my VA job. And if I did not pass it, I would not have had a job. And so I've had colleagues who had to postpone getting a job like for a year or two and had to do still intern level work because they can't pass that exam.
Hey, this could be a story for you,
Yeah,
you know,
no,
because I've heard
for
this
sure.
elsewhere, that the licensing boards are actually one of the barriers to increasing the workforce. That there's, and for sometimes bizarre reasons, it's worth looking into that, I think.
No, yeah, thank you very much. It's something that I hadn't heard about. Jennifer, do you have thoughts on that?
I agree. I fully agree. I have colleagues that have had to take it multiple times. It's very expensive. I took it myself. We have to take 2 in California. And if you were to choose to, during the pandemic, I had a client that in an emergency moved to Maryland and she still needed services. So I'm going online, like, how do we figure this out? And there was like some stipulation, but still, in order to even get Maryland to say, okay, because of the pandemic, you can see her, I still had to pay, fill out a form and pay, I don't know, $200 or something. And you would think you could just fill it out, or I don't know. I mean, that's not my world, but still, it's just cost after cost after cost after cost. I will say that there's just so much research we have on testing and folks that are minoritized. And so, you know, if you don't get the preparation in graduate school to take these exams, then it really is on you to find the study materials, and that's a big cost.
Wow.
It's a humongous cost. I won't age myself, but I had CDs that I had to buy. And I mean, it's just to buy the materials and then find the time to spend the hours and hours to, I mean, we need, I feel we need licensing, but if you're working full time and you've got to study to take the license and you've got to pay to get the materials that are going to help you get there, some people also pay to take training classes. And if you don't have the money, then you're just doing the materials at home. I've certainly had friends like, oh, can I borrow your materials? You're not supposed to, but they're like, I don't have a couple $1,000s to buy all this.
Wow.
You know.
Hi, my name is Barbara Griswold. My expertise is in helping therapists work with insurance plans. I wanted to add on to something that she said, which is many people aren't aware that insurance plans purposely try to keep their number of applications as low as possible because it costs them money every time they impanel each one of you. And so they
there are these ghost panels too, right? Like
exactly.
Providers pass
so
away,
all
move.
of us, even if all of us are on the panel, we don't want to take, somebody mentioned it earlier, we don't want to take anybody from that plan because they don't pay us enough. So there's all those of us who haven't resigned because we kind of are hedging our bets that maybe we'll need a client at some point. So there's all these people on the panels who actually aren't accepting, or they're dead. There's a lot of dead people on the list.
I've heard that a lot. People move,
I
people
see
die,
dead names
and the
as I'm
panels
going
are not
through
updated.
the list. But so you've got dead names, you've got people are calling and calling and calling and calling. So to your point, I don't hear that there is an actual mental health dearth of therapists. I think there is a dearth of therapists who are on insurance, who are accepting new clients, because those of us who take insurance, we're full, and we are overly full, as someone else mentioned. So I think we have these two worlds that are out there. I know my colleagues who are private pay, they've got plenty of room, and that's usually, they're always accepting new people. So that's point number one. Point number two, I'm amazed in all this time I haven't heard the word single payer. We have a very broken system, and I think you guys are talking about rearranging deck chairs on the Titanic. We need to be looking at a whole different system for this to be fixed. Either a single payer system or something more like Kaiser that has more integrative care, and where
But even there, you have massive waits. I mean, in
no,
California.
like a good version of Kaiser. Just take the integrative portion of Kaiser, where the therapists and the doctors are more working together, and it's more holistic care maybe. But I just think our system is so fractured, and so nobody's talking to each other, and it's really easy for clients to just fall between the cracks. Those are my comments.
Barbara, you must be from California.
Absolutely.
Because this is really the central lesion in California, is how fragmented the system is. We used to show, for the Department of Healthcare Services, we used to have a slide that had a family of 4, and every person, if they needed mental health care, would get it from a different source with a different payment line. It's just amazing. There's been a conversation here, even at the very beginning of the governor's tenure, about whether the behavioral health would be the place to start a kind of single-payer system. Could we do it here? It would unfortunately still be carved out, which is not great because it wouldn't be integrated with primary care. But there is an interest, oddly enough, from groups like Kaiser, which are obviously failing here, not provide, and taking a black eye on their behavioral health care. And they'd love to be able to figure out a way to do this better. When you bring all those private and public payers together, which we did in 2019 around one table, they all have the same pain points: workforce, there's issues around integration and all of that. Why not try to solve them collectively rather than trying to do it in the public system and then each private payer doing it independently? So I think it's a great point to make, and I do think there's some appetite to try to go in that direction.
Hi, I'm Dr. Donna Oriowo. I'm a sex and relationship therapist in the Washington, D.C. metro area, and I live in that intersection between diversity, equity, and inclusion and sexuality. And I guess on my end, I find this conversation both to be somewhat enriching and also very alarming, in that cultural responsiveness and culturally responsive care was not a forethought, it was an afterthought, much in the same way that I find that we already operate within the space of mental care in general. It is not to think of it through the lens of what are the barriers that are already existing within our system as a whole that then carry themselves into our mental health and sexual health spaces. So for me, when I hear this idea around supply and demand specifically, and I'm like, yes, it's definitely about the money, like if it ain't about the money, right? But it's also that there are way fewer therapists of color to see people of color, because that's where they want to go, because of the way that white supremacist racist patriarchy shows up in our mental health care spaces. So I guess my question then is, how does the white supremacist patriarchal capitalism impact the mental health care state from your view, and when do we make that a first act and stop making it the last act?
Who wants to take it first?
Well, I can take that on from the California lens. I know you're not from California, but in this state, it's pretty extraordinary if you look at the workforce that we have and how that's mismatched with the people we're trying to serve. And it's not only by race, it's also by ethnicity, it's by geography. There's a whole range of issues here. When we started to ask, what can we do about that? One set of answers is train more people that are more diverse. And it's hard to argue with that, but that feels like a very slow process when the house is on fire right now. What could we do right now? The governor decided that he wanted to focus on youth and children to address this. And so he put out this thing called the Children and Youth Behavioral Health Initiative, which was a $4.4 billion initiative to create a new workforce. And his commitment was that that workforce would have to match the youth, the children and youth of the state of California, 10 million people, who are remarkably diverse. And we were challenged in a bunch of ways. I mean, our first thought was that this was a question of racial diversity. Actually, in some ways, the bigger problem has been the geographic diversity, that many parts of this state have almost no one available to provide care. But we hit upon a really interesting opportunity, and that was that, and again, this is a California answer, but it's the best I can give. In this state, well, one thing we do have is an extraordinary community college system, 117 community colleges that are absolutely spread across the entire state. They're in every county, in every rural area. It's remarkable. And those were set up for just this reason. They wanted to, the state of California made a pledge to educate everybody, not just people in places where there was a Berkeley or a UCLA or a UC Santa Cruz. And so the question naturally arose, well, could that become the farm team? Could that be the way in which we would generate a new workforce by starting with this very diverse educational system and build from that? And so that's one of the ideas of using this new initiative, this new funding, to create a far more diverse workforce. But I would challenge all of us, I think, as we think about this problem, how to do something yesterday. Like what can we do right now that can begin to have an impact? And I think the governor's idea of building this, we may call it Coach for California. I don't think we have a name for it yet, kind of like Teach for America, but coming up with a way to really pull from the populations that you want to serve, empowering people to work within their communities to build community. I think that is very much the spirit of what he wants to do. And we'll see. And to Connor's point, it's one thing to put the money there, it's another thing to actually execute and get it done. But at least we've got an initiative and an idea of a way to do this today. I mean, right away, this could happen.
Go ahead. I mean, I have a lot of thoughts to this question. This is kind of what I was referring to when I said I'm calling my colleagues. I was talking about minoritized individuals who are looking for therapists, and they are not finding, they don't want to go to everyone else that might be available. But to your question about how do we kind of challenge this white supremacist, you said, capitalistic, et cetera, system, to me, one of the places, it has to be in education, and not just community college. I think, yes, that's one level, but someone at a community college, I was tenured at a community college for 17 years, they have to be ready to help that student get to the graduate level. So first, get them to transfer successfully. I mean, that's a whole other discussion. So you've got the population that might want to actually do that work. I can't tell you how many of my students come in saying, I want to be a psychologist, especially if it's like their first or second psychology class. They're like, and you do it? I want to do that. I'm like, okay, let's finish your 2 years, then you're going to transfer here, then you're going to go here, then you're going to, and they're like, wait, what? Oh, okay, hold on, But once they actually get to the graduate program, there is, I can't speak for the nation, but I am just going to say, even within the state of California, there is very little education that is even challenging these systems when they train the clinicians in the first place. So not only are you not preparing a whole, because to your point, if let's just say African Americans are only 13% of the population, you're not going to get enough, the numbers are not going to work out. So you've got to be able to train other people to be culturally competent. And that is not happening in a graduate program at all. And I don't think for example, a SimplePractice has multiple trainings to provide some cultural competence, but 30 minutes or an hour here, there's not going to be enough after the fact. You've got a student for 4 years or 5 years, if it's, graduate program of doctorate, so 2 to 5 years, where you could require culturally competent education at every single level. When I was in graduate school, it was a choice. We had tracks that you could choose. Some people could choose, child and family, and some could choose, I forget what the other one was. And then there was mine was called community, oh gosh, what was it called? Multicultural community psychology. And I knew this is who I want to work with. So I went there, and to me what was fascinating is if you were a person of color and you're walking down the hallway and you meet a peer, they'd be like, oh, you're in the cultural track, huh? And you're like, first of all, I don't appreciate, but also yes. And also, why is it only us in this, if you're Latino, oh, you're probably cultural. Yeah, I am,
Well, I'm so glad you brought up the education part, because one of the things as a reporter of color covering mental health, even just looking at sort of basics sometimes, we'll get advanced copies of psychology studies, experiments done on basic psychology, and the experiments are designed by and for primarily the individualistic mindset. And I have many times, I'm like, I don't relate to that. And so it goes back to even what our understanding of human emotions, how they manifest, how mental illness sometimes might manifest, and I'm wondering if, Jennifer, you or any of the other therapists of color in the room can talk about where, just an anecdote or two, where the training you've received in your education as therapists was and it doesn't quite fit the reality of a client.
My feet don't touch the floor. No, I have two comments to this. One is there are far too many anecdotes I'm sure I could give of just perhaps emotionality expressed by a client and that being pathologized, and not understanding that many different cultures might be very vocal or just animated in the way they express, and somehow that being called manic or something, and you're like, wait, no, I thought it was just a happy day with all. Then really the whole barbecue was manic. Then, if that's the case. But the second comment, which is getting back to this idea of the structures that have influenced our understanding of mental health, from the ground up, are not being challenged. So to me, there's a great book by Ethan Waters, which is called Crazy Like Us.
It's my go.
I love this book, and I taught abnormal psychology, and I made it. This was like the other text, because I didn't have another way to disrupt what an abnormal psych textbook is going to give you, which is very white supremacist, patriarchic, etc. This is what's wrong and this is what's right. I had to give something else to balance it out, because I'm teaching community college students who don't look like whatever the abnormal psych book is saying is the standard. So when we would read this book, and if you're not familiar, he's an anthropologist, but he focuses each chapter on a disorder and a country. So it's anorexia in Hong Kong, or it's PTSD in Sri Lanka. And so you start to see how maybe the US or Western kind of psychology understands PTSD, and then how they try to take it to Sri Lanka and say, this is what's wrong with you, and this is how we understand it, rather than being like, wait, how does this culture focus, and how do they heal, and how do they understand each other? So to me, I think more research and texts and books like that, that's what I meant by in graduate school, everybody having to learn that, and not just me in my little cultural track learning about these things, everybody. And I had peers we had one cultural competent type of class, and my peers complained, like, why do we have to take this class? I don't even.
Yeah. It's interesting. We so very early, the book came out kind of in the when I was still like in my first radio reporting job, and I interviewed the author, and we received some criticism even from science journalists saying that we had given credence to a book that wasn't well. So I love that book and I highly recommend it. So thank you for bringing that up. Any questions from, are there any questions digitally from virtual attendees? Oh, go ahead.
Hello, my name is Shani Tran. I'm a licensed professional clinical counselor. I also needed to stand up because I feel like my nervous system is like crazy right now. I wanted to introduce a new term because I'm hearing the word cultural competency. And as someone who graduated in 2010, I think it was. I remember that term, and I'm learning a lot from the new generation of therapists, and that is cultural humility. Yeah. And the reason why I want to bring that term up is because we're having these deep conversations, and cultural competency is something that can stop after a class and may lead people to believe that they can work with all people from different races, ethnicities, and cultures, and that's not true. Yeah. Just because I'm a Black therapist doesn't necessarily mean that every Black person can relate to me. But if I practice cultural humility, what that means is that I recognize my own biases, and it doesn't just allow me to be in the room with people of other cultures and other races and other ethnicities, but it also allows me to be able to understand them. And I wanted to comment on what you said about education. I believe that it does go back to education, because I think about, as a young therapist, when I was coming up, I think about being told that I have to work nights and weekends. And if you want to go into this field, money is not the reason why. And I remember sitting in my class and thinking, well, I do want to be rich one day, so should I change majors? And one of the things that I recognize for myself is that I am a person, and I wanted to bring that into the room because I think that we're not remembering that what we are talking about is human beings. I hear you talking a lot about numbers, and I hear everyone on the stage talking about clients, but we're talking about human beings. And as therapists, we are the biggest tool in the room because we're all people, we're all human. And if we can sit down and relate to someone because of who they are as a person, I think that that will change the game, because I don't know math, I don't do math, but what I do is I do people, and I know that people are looking for one thing, and that's to be seen and be heard, because they don't often get that in their real lives.
Thank you.
Wow, we covered a lot of ground today. I hope you enjoyed it. I also want to thank each of our panelists for the time. All of you on the live stream joining us. You're with us in spirit, I guess, but it's great to have you here. And I hope that we can also use this as an opportunity to continue the discussion. Obviously, discussion in our respective communities, other forums, and then certainly, hopefully, that SimplePractice can continue to be a place to support topics like today. So thank you, everyone, the whole team that put this together, and looking forward to spending time with each of you.